All right, thank you for your time, and I apologize.
I will. I'll do it. Okay. Okay, well, for those of you, for Dr. Lynn, Dr. Ricker, for those of you who keep score at home, we're going to do some pediatric critical care and emergency medicine board review. I'm going to say this is, you know, I'm not going to get to everything today, but we'll get to some stuff. So, all right. So here's a little bit about the board content specifications. I want to, oh, got it. I don't see where that is. What's that? Oh, how do I get that? Got it. Oh. Okay. Got it. All right. Okay. So, and part of this talk, I want to also talk a little bit about sort of how to take the test. All right. So here's the content specifications. You see all these. You can barely see that. You see all these different topics, and here's this is sort of the type of question you're going to get. This only makes up 4% of the board content specification, which means two things in my mind. Okay? One, you don't need to spend a whole hell of a lot of time studying critical care, but certainly nothing that big. Like other freaking oscillator. They are the nerd. Number two, 35% of the question, or 75%, sorry, 70% of the question is about diagnosis, management, and treatment. So it's not going to be about in-depth physiology. It's going to be a lot of, like you've always done, a lot of word recognition, a lot of test techniques, a lot of strategy, and a lot of figuring out what the question is trying to ask of you. Just keep that in mind as you prepare it, as we talk a little bit about it today. All right, I would like to go ahead and start with respiratory distress and failure. And of course, this is a topic near and dear to any intensivist heart. Should everybody's pediatrics, or we take pediatric boards. And sort of want to divide this up between, you know, sort of as you go down the respiratory tree. Okay. So let's start with the question. Who wants to read? Heather. Okay. All right. So we don't have to read that loud. Okay. You want Dr. Ricker, read out loud, please.
During an overnight shift in the ED, a fully vaccinated 20-month-old boy presents respiratory. Mother states that he has had a runny nose and cough for about 3 days. He'll notice that he's being agitated and struggling. On examination, you observe a fussy toddler and obvious respiratory distress. He is tachypnic and has inspiratory stridor on each breath. You immediately advise for stomach epi 0.5 cc.
I got this.
As well as oral dexamethasone 0.6 mg/kg. Upon reassessment 30 minutes later, you find the child asleep in mother's lap with minimal tachypnea and no stridor. Of the following, which infectious agent is most likely responsible for the child's symptoms? Parafluid encephalitis 1, mycoplasma pneumoniae, or Haemophilus influenza type B.
It's the 19th. Okay. That's morning, right?
Yes.
So the answer is parafluid. Okay. What does this kid have? Croup. Parafluid is the most common etiology agent of croup. Now, here's the thing. Test taking strategy. Does all this stuff matter? The fact that they receiving nebulized epinephrine and 5 cc's and a dose of decadron. The fact is that none of this, there's a lot of extraneous detail, which is the MO of the boards. One thing I always like to do, my biggest first piece of advice to give you, is whenever you approach a question, read what it's asking first before you read everything else. Because sometimes the question sometimes the actual question has nothing to do with all the filler above. Or you can read it then, or if the filler does matter, you can then read that filler with the lens of how's this going to help me answer the question. Okay, other little thing is this. Yes, you can immediately, if you don't know it, you can just immediately eliminate probably one of these, right? Which one? Good, why? It's fully vaccinated, right? So we don't see, I mean, it's not gone completely, but we don't see that proximal airway disease. What causes proximal airway disease? I'm talking from the upper the oropharynx through the intrathoracic trachea, right? Laryngotracheal malacia, croup, foreign body, and foreign bodies can also be vascular. Vascular ring slings and ring slings, vascular things, and then infectious things like RPAs and PPAs. Okay? What is the market? What is the market? The physical exam finding most associated with upper airway obstruction? Strider. Why? Because as you take a breath, right, as you lower your intrathoracic pressure, that causes increased flow of air in the upper airway and tends to promote collapse of the airway. All other things being equal, inspiratory findings tend to be extrathoracic. Inspiratory findings tend to be extrathoracic. Expiratory findings tend to be intrathoracic, pulmonary, distal airway. Okay. It works in the supine position. That's if they give you that piece of history, that's classic for something like laryngotracheal malacia. Historical factors. Kid who's completely fine, all of a sudden they're not. And a lot of them have respiratory distress. It's usually some sort of foreign body or infection. Okay. How do we treat this? Well, supplemental oxygen. It's your friend, as a wise old man once said. It's sort of my unofficial piece of advice. If you get a bunch of questions, if you have a question with a bunch of options, and the option is administer supplemental oxygen, 9 times out of 10, that's the first. And there's a bunch of diagnostic stuff, and the kid is in a lot of distress. That's usually the answer. Yeah, this is another test. Heliox. How does heliox work? Makes the expired gas thinner, promotes laminar flow. So Strider is caused by turbulent flow around the airway. Go down the middle of the airway where there's less obstruction. Racemic epinephrine decreases airway edema, swelling. Decadron is another thing that we use so often for upper airway obstruction. Different ventilatory modes sometimes if they need it. And then surgeries for things like abscesses and foreign body. All right.
What is the most appropriate next step for a 12-year-old girl with a severe asthma exacerbation who continues to exhibit increased work of breathing and poor air entry despite receipt of intravenous glucocorticoids, inhaled bronchodilators, magnesium sulfate, and who was placed on BiPAP 1 hour ago? A, perform endotracheal intubation and initiate invasive mechanical ventilation. B, obtain urgent CT of the brain. C, a nasopharyngeal sample of a respiratory virus polymerase chain reaction. D, initiate heliox. E, initiate turbidolene therapy.
Herb it is. Very good. All right. Distal airway disease. Most common we see is what? Asthma. Things like bronchiolitis. Foreign bodies also can get in the distal airway. And then also vascular malformation. Okay. So again, like I said, all things sort of being equal, expiratory findings tend to be distal.
No, you did not. However, her father-in-law came into town, so she ended up taking the day off.
Yeah. And so there is so anything prolonged expiratory phase wheezing is usually a distal airway.
What you need?
Airway obstruction.
Miss her?
Otherwise, non-specific signs of respiratory distress.
Yeah, I'm no longer part of your clique anymore.
Hey, Ashley, do you mind putting your mute on, please?
Yeah.
Thank you. Other hypercarbia, hypoxemia, asthma tends to be a more hypercarbic, or mildly hypoxemia, more hypercarbic finding. Okay, wheezing. Remember, wheezing tends to have an expiration. The worse it gets, it can have an inspiration. When you're not wheezing at all, you have silent chest. It's really bad. Bronchodilators. One thing you may find is that if it responds to a dose of albuterol, then it's probably more bronchospasm. You get a question or a real life scenario where it's not responsive to a bronchodilator, think more of things like bronchiolitis or foreign body. So fixed obstruction. It's not dynamic, Okay.
Dr. Dahlman,
Yes.
I have a question about that last one.
Okay.
So I get how in this case, terbutaline would be the right answer because it's increasing. You haven't done all the therapeutic things you can do, but also with that question stem, it's like if you've already tried BiPAP and the kid's not improving, obviously in asthma, you don't want to intubate if you don't have to, but like when do you say you go ahead and intubate because you've tried, like what's the threshold if you've tried everything else? Does that make sense?
Yeah, no, so I hear you. So so it depends on how bad they are. To me, I intubate asthmatics for two reasons primarily. Okay, one is mental status change. Okay, so either completely tuned in and non-responsive, or actually see this more commonly, panic, air hunger, super anxious, like really anxious. I mean, you know, I've had kids, teenagers grab my wrist and say, "I can't breathe." That's a kid who needs to breathe. If I wouldn't stop it, I would maybe I would be getting ready to intubate because I put the turbulent. And the other thing that I will also intubate asthmatic for is if they are profoundly hypoxemic. That's usually the last. Usually, you were saying before, hypercarbia in and of itself does not push me to usually intubate asthmatic. Hypercarbia causing obtubation, yes. Bad blood gas typically doesn't do it. But if you're so obstructed that now you're having a significant O2 requirement, you know, then that's a pre-arrest sort of state. And I would go ahead and do that. So it's one of those things. So now would it be absolutely wrong? I mean, it's one of those things. What's the best option, right? You know, I think in this question, I would probably try terbutaline beforehand. But I think your point's well taken that you know, because of how bad this patient is, they might end up intubated, or you might go ahead and intubate them the minute they hit the door.
I would say for asthma, just knowing that they need to be severe before you tube, because like intubating doesn't necessarily help them as well.
Right. It's really truly saved their life, like at that point, where you got to be pretty sure. Like I said, the asthmatics that I've intubated, I'm pretty sure that if I don't do it, they're going to arrest soon. And so anyway, okay. Good question. All right, foreign body. So remember we talked a little bit about foreign body in the upper airway. If you get a picture like this, think about foreign. So again, historical clues to foreign body. A kid who has no history of asthma, no history of wheezing, was at dinner, all of a sudden cough, choke, and has been wheezing since then. That's usually a foreign body. And if you get a picture like this, what is happening? This is an expiratory film, that's an expiratory. Exactly, it's a ball valve mechanism. So it sits there, air coming in. So on expiratory, what you'll classically see is an expiratory film where shift, you can see that on this left side, hyperinflated and medius side shift away from where the foreign body. Okay. It's a little bit that way on the inspirator, but you see there's a difference between inspirator and expiratory. That's usually a chip off. That it could be foreign body. All right, how do we treat distal airway disease? Oxygen, your old friend, right? Support other supportive care from anything from nasal cannula to CPAP, BiPAP, invasive mechanical ventilation. Asthma, of course, first line bronchodilators, steroids. IV stuff, terbutaline, anaphylaxis. As I say here, you will never see anaphylaxis on the boards because, please tell me if you do, and I'll stop saying that. But you'll never see anaphylaxis on the boards because everyone hates it. And I think that's horrible. I think that's unjust. Anaphylaxis is a great drug, but the rest of the world hates it.
If you see it, it'll be about the neurotherapeutic index from a pharmacy standpoint.
Right. Yeah, that's true. You will see. You will not be given anaphylaxis as an option for your asthmatic because the guidelines crap all over it. Again, other things like MAG, inhaled. I doubt you're going to get that far down. You might see magnesium as an option. You're not going to see sevoflurane and ECMO as an option. And then foreign bodies, of course, best they can do is surgerized removal. All right, I'll read this one. Give Dr. Worthy's one. A 4-year-old boy with a history of refractory epilepsy is admitted to the ICU after a prolonged seizure at home. complicated by vomiting and a difficult intubation field. He remains intubated in the ICU and is given high-dose benzodiazepine infusion in an attempt to control his seizures. 24 hours after admission, he develops a new oxygen requirement. A chest radiograph is obtained. Pretty bad, huh? At the time of your examination, the patient's oxygen saturation is 90% on 100% FiO2. Arterial blood gas testing while the patient is in pressure control ventilation with a mean airway pressure of 14 reveals a pH of 7.23, a partial pressure of carbon dioxide of 67 torr, a partial pressure of oxygen of 50 torr. Which of the following is the most likely cause of the patient's hypoxemia? ARDS? ARDS it is. Okay. Again,
It's
you
a
can.
really good example of that question.
Right.
All the ventilator stuff is bullcrap.
Yeah, exactly. All this stuff. Who cares what the gas is? Honest. Well, for the definition of ARDS, all you really need is this X-ray. Tell you what he has. Status epilepticus doesn't really cause persistent status epilepticus itself does not cause hypoxemia. If you're not intubated, it might, but not for an intubated, right? A pneumothorax, well, I mean, you really see pneumothorax, and you're static 100, and there's not really big pneumothorax on that X-ray. Ventilator-assisted pneumonia is only be on the ventilator for 2 days. I mean, probably not. Hypercapnic respiratory failure, yeah, he's got that, but but that's not really the cause. So parenchymal lung disease, things like your infections, your pneumonitis, ARDS. So what is ARDS? Dr. Warren. Okay, so you know, what ARDS is pathophysiologically is an insult to the capillary, the interface between the pulmonary capillaries and the alveolar epithelium, right? That leads to an inflammatory, either a direct insult to the lungs or a systemic inflammatory insult that leads to breakdown of the membrane between the pulmonary capillaries and the alveolar epithelium. Potentiates inflammation in the lungs and causes, most importantly, an exudative pulmonary, non-cardiogenic pulmonary edema, and fiber deposition and further like remodeling the lung architecture. So basically, it's either a direct insult to the lungs, which causes lung inflammation or a systemic process like sepsis or a burn. This is actually smoke inhalation that I took care of in fellowship. I took a screenshot because it's a very good ARDS picture. Or a systemic inflammatory response that sort of gets potentiated in the lungs. The criteria for ARDS diagnosis are acute onset, bilateral in an adult, or can be unilateral in infiltrative chest X-ray. A PaO2 FiO2 ratio of less than 300 for adults, or an OI, oxygenation index, I believe greater than 4, or is it? I don't remember. In kids. Was it? Yeah. But again, who cares? For the boards, you're not going to bilateral, exactly. And then it can't be cardiac. It's fully explained by just hypostatic on the left side. Okay. What this does, this exudate causes a BQ mismatch, causes decreased functional residual capacity, and that's what causes the AA rate. Okay. But again, with that question, you're right, as Aaron is just saying, bad hypoxemia, bilateral infiltrates on an X-ray, that's all. Is that ARDS? That's all. You don't need to know about all the other crap.
I'd like to get the short vignette and a picture of X-ray, say what's the cause of it? Asthma, pneumonia, ARDS, or heart failure. So the hardest to differentiate would be heart failure and ARDS from an X-ray, but the vignette, the little bit in there is going to tell you too. Confusion versus.
Okay. All right. You want to read this one?
Which of the following next steps is most appropriate to help minimize the risk of ventilator-induced lung injury in a 4-year-old boy who developed respiratory distress? Ingesting a hydrocarbon is currently on mechanical ventilation with a tidal volume of 36, a pH of 7.35, a partial pressure of carbon dioxide of 47 millimeters mercury, and a partial pressure of oxygen of 8.
So what's the question asking? There's a lot of verbiage in there, most of which doesn't matter. How do you decrease the risk of ventilator-induced lung? The thing about things like barotrauma and volume trauma, oxygen toxicity. All right, so try to eliminate. What can you eliminate? Do you want to choose the title volume?
I haven't.
Okay, yeah, okay. Talk it out. What's up?
This is P is 6. But is that why it's also 5?
Or would you want to increase your? Right.
Oh wait, no, you don't want to increase.
Right. You got to read the question. Read the answer.
Yeah.
The answer is
Good. Your thinking's good, and if you don't,
Right.
you didn't know any of the like per se guidelines, but to realize that 6 isn't that bad of a peep.
exactly
Peep's actually helpful.
helpful,
So
right?
knowing that 6 is bad, so low tidal volume is helpful
Mhm.
and.
Right. Volume trauma is the main thing. And actually, this you may see. Actually, if they ask a question about ARDS, they may ask. They're not going to ask about numbers and what the tidal volume should be, or static and compliance and all this other stuff. They might just ask you to recognize that too much stretch in the lungs is not good for ARDS, right? Okay. So how do we treat parenchymal lung disease, like we talked about? It could be anything from a little bit of oxygen up to up to ECMO, really. And for ventilators, I doubt you need to know a lot of the finer points of ventilator management from the boards, but I would know that too much tidal volume can be toxic. I would know that to increase oxygenation, playing with your PEEP or your mean airway pressure is the right way to do that. To increase ventilation, your tidal volume, increase your minute ventilation, tidal volume, or respiratory. And then just be aware of non-conventional modes like the oscillator. Again, I don't think they're not going to ask you for oscillator settings or how the oscillator works. They might just ask you. Other things that can cause respiratory problems. Congestive heart failure, pulmonary overcirculation. Historical clues kind of go with this. An infant who fatigues while taking PO. That is pretty much always heart disease or some sort of overcirculation or heart failure, unless there's something in question that's directly away from that. Cardiomegaly on an X-ray, you may see that also. Diuretic, treatments, the finer points of treatment for heart failure is probably not going to get beyond the boards. And these are all this is all my, I don't have any inside knowledge of the boards other than having been around and standardized. But I find it hard to believe that they would actually ask you to really prescribe a regimen of inotropy and diuresis. Just know that a lot of fluid's not good for them. Diuretics might be helpful. If you need an inotrope, usually low dose epinephrine or maybe a little Parenchymal. Even that is probably good. Altered mental status, like lots of intoxications, seizures, all that kind of thing. Decreased respiratory drive, decreased airway protective reflexes. Basically, the way you might end up seeing this on the question is if you get a GCS that's less than or equal to 8. And how do we calculate? Remember, you guys have had me, and I love the GCS. When we talk about altered mental status, I hate terms like obtunded, stuporous, comatose, they don't mean a lot. I love the GCS because it's not perfect, but it's objective. And you can sort of get a sense of the patient's ability, especially for protecting the airway. And usually, if it's less than 8 or so, you would want to go ahead and secure an airway. And I don't know if they would ask you to calculate a GCS, but
I feel like I remember one in PEEP boards where I needed it, and I'm not a good memorizer. And so I mid thing, it's like, oh God, I can't remember. I know that they're doing this question, but I can't remember that calls. So the GCS was one that when I took people course now, I would probably recommend it for kids too, that I had a sheet of things that I memorized. And that's one of the things is when I got there and just data dumped everything that I memorized stats.
Oh, yeah.
That it's a lot of memorization for one question, but that's one question that I'm definitely.
Yeah. And that's kind of the way I feel about these questions in general. Like, it's not going to be in depth for peds board. It's not going to be in depth critical care questions. Some of these can really be gimme questions too, because they're going to try to trick you like everything else. But you're not going to have to, don't study the biochemical mechanism, by the way, norepinephrine, or what cytokine does which thing or whatever. Not. But very basic PALS, life support kind of critical care stuff. And particularly toxicology, those are gimme questions. That's exactly what Dr. Ricker said. Those are ones of straight word association and should people get all of them. All right, so what's the definition of respiratory failure? Do you know who this is? I know that's what Potter Stewart is asked. The Supreme Court was asked to define what obscenity was, and he goes, I don't know, but I know it when I see it. That's I kind of feel the same way. Respiratory, there's not really a great definition of respiratory failure. Okay, so if you look in a bunch of textbooks, you're going to find all sorts of different definitions. But a lot of them based on blood gas analysis or whatever are arbitrarily fairly useless in clinical practice. But you might on boards, because they like throwing numbers and little clues and tricks. You might see something like a PaO2 of less than 60 or hypercarbia greater than 50 torr. Again, in real life, that doesn't matter. I've intubated kids in respiratory failure with perfect blood gases, and I've let kids with horrible blood gases let it ride. Depends on the clinical context. But so signs of that being said, there's some things that might tip you off in a board question as in real life as to like when to go ahead and like initiate mechanical, non-invasive mechanical ventilation, intubate, that kind of thing. So impending worsening work of breathing or diminishing respiratory effort, the proverbial tiring out. Grunting is kind of an ominous. What is expiratory laryngeal breaking is a fancy term for it. What is grunting? Yeah. Right. So you're using your glottis at end exhalation. You're actually prematurely terminating breath. You're using your vocal cords as a heat valve, essentially. You are trying to preserve FRC, trying to limit atelectasis and collapse of the airways and expiration to maintain some gas exchange. Usually a poor sign that the baby or patient's taking everything, all their effort to maintain gas exchange. And then mental cyanosis, altered mental status, again, that's somnolence or okay. All right, moving along. Anything on respiratory? And folks watching at home, and feel free to chime in. Any questions on respiratory? Respiratory stuff.
The only thing I'll throw in that they like to ask is resistance in the airway size. Cut it in half.
Yeah.
It's always cut in half. And the resistance. Another easy point.
Okay. Shock. What is shock? Well, failure of the cardiovascular system to provide typically metabolic substrate, really oxygen, to meet metabolic demand. There's a supply and demand problem. The end result being there's something keeping from blood getting to where it needs to go, dropping off. Okay, causing anaerobic metabolism, ischemia, cell death, ultimately. So how do you classify shock? Well, again, read 5 different textbooks, you're going to get 5 different ways. To me, I like breaking it down as a problem with the pipes. I'm sorry, with not enough gas in the tank, hypovolemia, problem with the pump, cardiogenic, problem with the pipes as it distributed. And from there, immediately, hemorrhagic shock can certainly cause decreased hemoglobin and oxygen, but in transsecondary artery, it's really hypovolemia. Right? Cardiogenic shock, and I can throw some of the obstructive etiologies into this, like angiotheoresis and cardiac tamponade, all that kind of stuff, because blood can't get to the heart or come out. Neurogenic shock, high spinal cord injury causes decreased sympathetic tone, massive vasodilation. Anaphylactic shock tends to be a distributive, again, massive mast cell degranulation. Okay, massive vasodilation. What etiology of shock I very obviously left out here are the most common. Right. Septic, because it's all three. We tend to talk about septic shock interchangeably with being a distributive phenomenon. Believe it or not, especially if it's actually more of a cardiogenic type of. But certainly can be all. All right. So again, shock. You kind of know it when you see it. It's a clinical diagnosis. Tachycardia, diminished pulses, either thready, cold shock where that clamp, quote unquote, clamp down kind where you have thready pulses and 5-6 second cap refill, or when you're vasodilated, bounding pulses, flash cap refill. Altered mental status. Remember, the brain is an endorphin, right? So if it's poorly perfused, the brain's not going to work well. Then hypotension. Remember, in children, very specifically, and you will see this probably in some form of the boards. You're going to be given a kid in shock that has a normal blood pressure. Do not be reassured about it. As in life, do not be reassured about normal. Okay, very specifically, shock in children is not defined by hypotension. If you are hypotensive, chances are you are in shock, and you can be in shock and have a normal or even high blood pressure. All right. Good.
5-year-old with pneumonia presents with altered mental status and fever. She's tachycardic, has a calculated refill time of 6 seconds, and blood pressure of 95/50. Labs are obtained, and results are as follows. White blood cell count 25,000, 80% neutrophils, 15% bands, hemoglobin 7.5, hematocrit 23, potassium 3.4, bicarbonate of 14, creatinine 2.5. What is the most appropriate next management of this patient? Infuse IV fluids, transfuse PRBCs, give bicarb, or consult nephrology for dialysis?
Yes. Right. Yeah.
The amount they simplify ICU on the boards.
What? That's why I threw this in there. Guys, you know this stuff. If you spend 5 minutes in the PICU, which I know all you have, you're going to be working. But if you read the materials that we've given you guys, okay? So all shock management needs to begin with achieving adequate intravascular volume. Now, keep in mind, patient may already come to you with adequate intravascular volume. More time you spend not, you are going, fluid is going to be the answer. Might not always, we'll talk about that. So remember, what are we trying to do? What do we give? We give isotopic crystalloid typically in the first, as a first resuscitating measure. I mean, you're not going to be asked to give albumin. You might be asked to give somebody blood in the trauma bay who's sanguinate, who's very clearly sanguinate. Probably not. Even then, usually, as we're ordering the blood, start IV fluids. But be careful, right? If you end up having a kid with no cardiac history, again, probably not going to see this to any extreme extent on the PEDS boards. But if fluid worsens your situation, the patient has a huge cardiomegaly and a gallop rhythm on an exam, that's there for a reason. And those clues are there for a reason. You might not want to. You might want to get an echo, start a minor stroke. All right. Other thing you got to keep in mind, if fluid shock remains fluid refractory, is the shock warm, cold? Is the problem low cardiac output, which I would throw hypovolemia into that for the purposes of this discussion. Low systemic vascular resistance, or both. All right. Cold shock is the one we see most commonly, particularly in sepsis cases, where it's low cardiac output, high systemic vascular resistance. Remember, think about blood pressure. This is an oversimplification. Think about blood pressure as the product, mathematical product of flow and resistance. Slows down, resistance goes up. Blood pressure stay about the same. Now, as that fails, SVR goes down. That's when you become hypotensive. Warm shock is more that vasodilated, that high cardiac output, low SVR, bounding pulses, flash cap. And you can use it. Why this is important is you use this sort of mental model to figure out what kind of inotropic or vasopressor, what kind of vasoactive support. So if you have a low cardiac output and a cold shock that's refractory to fluid, you typically start with an inotrope. The prototypical one's epinephrine. Okay, dopamine you may see on there too. Low SVR, warm shock, you need was a vasopressor. We use the word pressor all the time here. interchangeably, we use it for just being on something that raises your blood pressure. Reality is that there are two types of inotropes. There's inotropes and there's vasopressors. There's overlap between the two, but you choose based on what action you want to prevent, higher cardiac output or lower SPO. And for vasopressor action, typical ones leave them at one. Sometimes vasopressor too, but a doctor can be asked to give that for shock on the. Again, reducing, remember I talked about shock being a supply and demand problem? Why do we intubate people with shock? Even if they're not in respiratory failure per se. If we take away all that demand of work of breathing, we can sedate them. We can actually, if the problem is supply versus demand, if we reduce demand, their supply, we can adequately supply them. Then of course, treating underlying causes of infection, if we've got a cardiac tamponade, show the needle. All right. An 8-year-old boy with a recent upper respiratory illness presents with tachycardia, hypotension, hypoxemia, lethargy, cool extremities, prolonged cap refill time, diminished pulses. On presentation, his lungs are clear to auscultation bilateral. He's given a 20 ml per kilo normal saline bolus, after which his hypoxemia worsens, and bilateral lung crackles become evident on repeat auscultation. Which of the following studies is most likely to reveal the cause of his worsening respiratory status? Spiral CT of the chest, lung biopsy, ventilation perfusion scanning, echocardiogram, or lung voltage? 100%, yeah. So you might actually, this would be maybe, this may be about as tricky from a critical care standpoint as the boards might get, in the sense of you give fluid, kind of like we always talked about, fluid is always the answer. Well, they may try to trip you up with this and say, well, you give that first bolus and they show signs of fluid overload. Usually the answer is going to be get an echocardiogram, as it is in real life. The take-home message for real life is always reassess. This is why I love shock management, because this is the only way you can know that it's every intervention you make, go to the bedside. The only way you know if it's working is by laying hands on the patient, listening to them. But you might actually see a kid in shock on reports who gets fluid and gets worse. And that's a heart problem, not 100%.
This might be a little bit oversimplification too, but like a recent URI and that being a problem. They're not febrile, they're not more that way. And then they might give that same vignette and ask what drug to treat them with and have epi, norepi, milrinone, and they want you to say milrinone.
Yeah. Unless the blood pressure is bad.
Milrinone heart, we don't do a lot of milrinone.
All right. And you want to read?
Yeah, 11-year-old boy who weighs 35 kgs presents to the emergency department after being stung several times after stepping on a wasp nest. He is complaining of difficulty breathing and has marked facial swelling and a diffuse urticarial rash. Vital signs are obtained. His heart rate is 180, blood pressure is 70/35. What is the most appropriate next step in treatment of this patient? Sub-Q epi 0.3 mL of the 1 mg per kg. Benadryl, IM epi 700 ml normal saline bolus.
All right, let me ask you before we get, this is actually a great question of things. There's like 3 things you can eliminate right away. All right, what can we eliminate? Thank you, absolutely. Yes, perfect. Because why? Because we don't give, for anaphylaxis, we don't really give something continuously, right? So this is actually a common board chicken. Right sounding medicine, wrong root. Does Benadryl do anything for anaphylaxis? No, it decreases a rash in itchiness, right? You're not going to, this kid's about to die from his anaphylaxis. You will hit him with Benadryl, it's not the first thing, right? The saline bolus, I mean, you're not really, he's hypotensive, something like that, but you're not, again, that's not the definitive. So it's down to these two. And I don't know, I got this out of some practice questions. It's rare that they would have something, I think, on the boards like that.
It's interesting that they did milliliters.
Yeah, that's my point. But the thing is, my point, part of the reason is this kid has anaphylaxis, and the answer is I am happy, obviously. I have a 0.3 to a 1, what used to be called a 1 to 1,000 or 1 mid per ml.
The other thing, this one I think is good test strategy wise, if you had no clue. If you know, if the answer you know. If you had no clue. So there's several that are very similar. So you have 2 that will say give IV epi. One says 1 milligram and the other says 0.1 is the difference between those 2. Well, guess what? 1 milligram is the only other one that's different. So the answer that has the most repeated options as you
Yeah.
go. Does that make sense? And again, use that if you have no idea.
Yeah, I didn't say that because I know that's a thing, but I think it is, and I've always sort of used that too.
Yeah.
You can sort of get onto their tricks, you know. All right, anaphylaxis. I mean, I'm not going to get, we don't need to spend that much time talking about anaphylaxis again. It's kind of obvious. They're going to, the question on the test is going to be very obvious. It's going to give you some piece of history, like, you know, for the stuff on the wall, you know. The treatment is IM epi for true anaphylaxis, life-threatening anaphylaxis. Plus all the stuff that's never been proven, you know, all the stuff that's not life-saving, symptomatic, you know, like steroids, Benadryl, ranitidine. You might get asked to give some racemic epi if they've got a Strider, but really probably anaphylaxis again. Give epi, and you can repeat it every 5 minutes or so, and make sure they protect them. And for shock, you know, so it's rare. Have you ever taken care of a kid with anaphylactic shock and true, like hypotension? I remember that I had. Really? That's scary. I didn't take care of my hair about that. All right. Heather, you want to read?
A 14-year-old girl with a history of depression presents with fever, tachycardia, mild hypotension, agitation, blurry vision, acid ingestion, a handful of her prescription pills. On exam, her pupils are equal, dilated, and minimally reactive bilaterally. Her skin is warm and dry, and her abdomen is distended with hypoactive bowel. An EKG is obtained, which reveals sinus tachycardia, a QRS duration of 120 milliseconds, a corrected QT interval of 460 milliseconds. Venous blood gas and finger-stick glucose reveals the following: pH 7.3, carbon dioxide 44, bicarb 22, base -3, glucose 1.
Okay. So, first of all, I know what you took, but that's not what they're going to ask you. What is the most appropriate, what do we give this patient? Okay, so what did she take?
Amateur.
Right, which is what?
TCA.
Right, so what do we give for PCA? Absolutely, yeah. And I'm going to actually come back to this question later, like, a little more anticipated, right? Because there's so many like clues, clues as to what. But basically, yes, this patient took a tricyclic antidepressant, and sodium bicarb is the antidote. All right, so poisoning and toxic, I love for boards because these are giddies. This is just pure word association, and it's just know the toxidrome and know the antidote. Toxidrome is kind of a busy slide, but if you go back and read it, know your toxidromes, particularly the anticholinergic. They seem to really love that one. You know, the red as a beet, mad as a hatter, can't see, can't spit, can't pee, can't, you know, like that's one I like. But basically, pupils. The pupils are always you're always gonna get a pupils. They're big, anticholinergic, they're tiny, they're getting, or sympathomimetic. If they're tiny, it's usually no quantity. One or the other. And again, there's other clues too, like, you know, acid-base status, anion gap, osmolar gap. Yeah, I don't really spend time calculating all that. The anion gap maybe, but
The osmolar gap, you might get a kid found down in the garage and their labs are fairly normal. And that's the only thing that's different is they have that
I'm
gap.
getting to that question.
Okay,
I'm
then
sorry.
never mind.
I'm kidding, go ahead.
So that would be the only time that comes up, but you know what the question's gonna be. And then as far as those toxidromes, exactly right, they love Benadryl. And then I feel like the other thing that they like is the LSD. Now, opioid might be more likely now. Just
There were a lot of opioid in the question bank I saw. There was a lot of them.
Yeah.
And synthetic cannabinoids too, which weren't as big of a thing when I took the board 12 years ago. So that seems like it makes you feel old. Anyway, other things. Calcium oxalate crystals, ethylene glycol. So in Mississippi, I took care of a kid around Christmas who came in with a horrible metabolic acidosis, intubated. The only thing we actually found calcium oxalate crystals in his urine. At that same time, his twin brother, parents were going through a nasty divorce. Twin brother said, "Dad gave us some Kool-Aid. Tasted funny. I spit mine out, but some John and John gave. Dad tried to poison him." Horrible, right? But those things stick out. Those things stick out, right? Calcium oxalate crystals is going to be ethylene glycol. Know some basic EKG findings. So like AV blockade, which in ventricular tachyarrhythmias for tricyclics, at QRS, so QRS should be about 100 milliseconds. QRS prolongation is usually a TCA. QTCs, pretty much anything can cause a prolonged QTC. But antidepressants, antipsychotics like Abilify, like risperidone, and aripiprazole. And then you may get some tox screens on there. Check with glucose, particularly in ethanol, alcohol ingestion, hypoglycemia can be something that, and that's one of those sort of, it's almost like an ABC kind of thing. It's an easy thing to check in case of either a poisoning or a seizure. Our friend Mr. Yuck with his 800 number. Always call poison control. This is real life. Always, even if you know what to do, always call poison control. It's just easy to do. They keep track of this stuff. They will be there to help you. Immediate ADC stabilization of these patients. Gastric decontamination and activated charcoal. I would stay away from those on the boards. Right. For example, okay, so I'll read this one. A 5-year-old boy is brought to the emergency department by EMS after being found unresponsive in the family garage with an open, unlabeled bottle next to him. The patient is obtunded and no history can be obtained. Loud voices do not elicit a response, and he's taking rapid yet deep breaths. He has a BP of normal, heart rate of a little bit tachycardic. Our respiratory 24, temp is he's afebrile. He withdraws the sterile rubs. Pupils are equal and reactive. Ones are clear auscultation bilaterally, and abdominal examination benign. Lab testing reveals the following results. So you see here, he's got a metabolic acidosis, negative UDS, negative ethanol. Other lab values are more or less normal. I agree. Yeah, that's true. Yeah, he's good. Right. Got some crystals in his urine, right? I mean, I don't. Which of the following is the most appropriate next step in the management of this patient? So what do we take? Right. So the antidote. Right. So what's the antidote for it? This is what. Know this one. This is a favorite. Omeprazole or ethanol. You could do ethanol too, but we typically don't do that much anymore. Or dialysis. Even hemodialysis is normal, but omeprazole is one of those word associations. But again, what can you immediately eliminate? Is naloxone? You probably didn't take an opioid with clumsy. Yeah, exactly. I mean, and gastric laws activated charcoal. He's not really. So one, who knows when he took it? Number two, he's not protecting his airway. Like you're not gonna shove the NG tube out and start and wash out the stomach for that. So even if you didn't know the antidote, if you had a brain lapse and you forgot it, you could then just eliminate these three. And yes.
You're between calcium carbonate, which you think of with heart stuff.
Right.
That should be fine.
So again, this is all word association. This is again why I think these questions are given. These are ones that you write down and you look at the night before. Remember the big ones: acetaminophen, of course, NAC, carbon monoxide. Throw a non-rebreather on them and call your hyperbaric oxygen specialist. Like I said, ethylene glycol and methanol. That's a favorite one. Methazole is usually one. Other things here, naloxone, organophosphates. They love that. Sometimes atropine or prylinoxine. Then TCA is bicarb. But all these are some common ones there. All right, DKA, I'm not going to talk a whole lot about it. We see right. So DKA is what? It's a starvation catabolic state because the body is created by the fact that the body has no insulin. Usually type 1 to use glucose. Causes gluconeogenesis, glycogenolysis, lipolysis. Causes ketoacidosis to build up, and osmotic diuresis, hyperglycemia, dehydration. Okay, so we if you spend time to pick these are a dime a dozen. But again, fruity breath in the board, fruity breath, I love that one. I usually don't get close enough to smell the breath. But Kussmaul respirations is deep, the rapid but big breaths, and then altered mental status, signs of dehydration. These are the definitions. Again, pretty self-explanatory. So basically, give a bolus over an hour for your recarded DKA. Start an insulin infusion. Make sure they don't get hypoglycemic. they start having mental status problems, what do? We give them some mannitol. You might see that as far as a patient developing symptomatic cerebral. All right. I'm going to fly. Previously, we're running out of time. Previously healthy 10-month-old has seizures. Okay. What are would be the glucose is normal. Yes. Yeah. So sensibly, you're probably not going to get a lot of. Basically, what I would know about status epilepticus is the operational definition of it is 5 minutes. So the definition of status epilepticus has changed like 4 times since I graduated med school. Basically, what they've settled on now is if you're not, even though there's sort of impending status, which functionally they're saying is status epilepticus, because at 5 minutes, basically the chances are that it's not going to terminate itself. So requires some intervention. So usually that will require, like I said, administration of benzodiazepine. And if you give it usually after as in real life, if you repeat that again and it doesn't break, or they're seizing intermittently, then they need a second line. Phosphatidone tends to be the one that we do the reach to. A baby, you might want to think about phenobarb, but if you do phenobarb, get ready to intubate them and give them a pulse because the cardiorespiratory. All right. Are you going to read this one?
19-year-old female college soccer player presents to the ED 30 minutes after head collision on the field. She reports that she lost consciousness for 2 to 3 minutes after the event, but did not vomit. She was asymptomatic upon arrival to the ER. After an hour of observation, she complains of severe headache and photophobia. Vital signs remain normal. Pupils are equally in size and reactive. Stat head CT is obtained, which looks like that. Which is the most important next step in management? MRI, education, administer mannitol, transfer to PICU, and immediate neurosurgical.
She's showing.
What do you see on your CT?
I mean, chest subdural.
And
I mean, not subdural, epidural.
So I suck at memorizing. So epidural, it's more likely to be your artery, more force behind it, can push stuff out of the way. Subdural vein.
And so this patient, she is symptomatic, but she's not herniated. Pupils are fine. She's not have Cushing's triad. So the better answer, the best answer, this means surgery. This needs to be evaluated. Okay. TBIs, they can range severity from mild concussion to severe, which is GCS less than 8. I'm not going to get into them, but a right area for questions is like the key turn rules. When is it okay to discharge a kid? What kind of instructions do you have a family for mild TBI, that kind of stuff, when to admit. I would also, kind of like Erin was just saying, I would also learn some basic lesions on CT to pick out. And really the big ones, a subdural hematoma, it looks like this, see it layers out among the gyri, so that's right up against the brain. An epidural is usually the football shape. It's usually an arterial middle meningeal artery. It's usually an arterial bleed, and it just sort of it grows. It pushes the dura in. If it's subdural, usually it layers out. You might see a skull fracture too. Not going to get into really all the very specifics, but herniation, they hyperventilation, 3% saline or mannitol. They love mannitol still for some reason. Kind of what we go into clinical practice. And then think about surgical options for an epidural. That's the typical talk and die, the lucid interval kind of stuff. That's always, surgery is always the answer. Unless the patient comes to the ED and they're blown a pupil and they're clearly herniated, then you might want to get Proximal there. And real quick, and we kind of been talking about this the whole time, just a little sort of some strategy. For these questions, first identify what they're asking. Read what they're asking, because so much of the verbiage can just be eliminated. And so much of that is just there. It's superfluous and or confuse you. Read the entire question, but look for buzzwords. Okay. Some of them may not even be medical, like specific background details, past history, social situations like the garage down next to a bottle, geography. Like if you have a patient with respiratory distress and look that not be from Ohio, it's just a plasma. You know what I mean? Like the reason that he's from Ohio is not because they're not going to get in there to say that he's a Cleveland Browns fan. You know, it's in there to point you in a very specific direction. Those are there for a reason. And eliminate things that don't make sense, like wrong administration routes. So like that sub-Q epinephrine and anaphylaxis. If it's a life-threatening situation, don't choose lengthy diet. So they'll give you options sometimes for like a BQ scan or MRI, like an awesome MRI brain. It's completely right. So you can immediately eliminate these sort of especially lengthy diagnostic studies in life-threatening situations. So coming back, so for example, using this sort of strategy, coming back to the question about the girl with PCAs, right? So first way you look at what the question's asking, right? So this is going to be a next step in treatment. So you probably need to make a diagnostic option, but you also got to start thinking about what you can do. All right. Toxidrome, for toxidrome, you get your toxidrome. Very anticholinergic, which is typically a PCA. She's got depression. She's got prescription pills. Okay, those are big tip-offs, right? Then the thing, QTC. And then, do you really care about what this blood gas is? No, it's practically normal. And I mean, you don't even need to look at that at all. So that's kind of the way you can dissect these questions. You gotta be careful because you don't want to miss stuff, but at the same time, you don't want to spend a lot of time on things that don't. I highly recommend Zeltelli's. Have you ever seen it? You guys have this? Yeah, is it still? I know this is my old version. For those of you looking at home, you're all welcome to borrow it, return it. But it's a well, you guys are going off into the world. You'll never. But anyway, the pictures in that book are on. They use pictures from that book on. I would say starting like the week before at night when you're relaxing with a glass of wine by the TV or something like that, or just start, or if you take a beach vacation in the summer, just flip through that and just look at. Just don't read. Just look at the pictures of the caption. I guarantee you, there were like 4 or 5 pictures that are straight out of that book on the test. All sales choose C. My strategy. So it's kind of work for me. Although it didn't work for whoever took this test. That's all I got. All right. Do you have any questions, Heather? Anybody have any questions? Anybody? Virtually have any questions? All right. Thanks for playing. Good luck, everybody. Congrats.
Thank you, Dr.